Okay, so we're going to be talking about readmissions, my favorite topic in the entire world. I've been basing the majority of my life, professional life, and sometimes my real life on it for the past 15 years. We're going to be talking a lot about, what's going on in readmissions, where we're at currently, some of the things that have been done about readmissions, but we're also going to be talking about future state and what do you think is going to be happening in trying to curb readmissions. So my disclaimer, there's no potential conflicts of interest. Everything is cited to source or is the opinion of myself.
Colleen,
Any, yeah.
we're getting a double screen.
Oh, good
Yeah.
Lord. Hold on one second. Display. How's that?
Better, thank you.
You're welcome. Yeah, I know it gets a little weird. All right. Any products referred during this presentation are solely for the purpose of example and should not be taken as product recommendations nor endorsements. And that includes the Coca-Cola that you will see me occasionally drinking from, although Coke really should be supporting me for the rest of my life. All right. Introduction. Since our implementation of the Hospital Readmission and Reduction Program in 2012 under the Affordable Care Act, it's also referred to as HRRP. It has really been the cornerstone initiative about how do we improve patient outcomes. We've been working on it since 2012, everybody, 2012. And a lot of people were looking at it even before then going, there's something going on about this. 2012 is when they officially made it, official. And how are they doing that? Well, we all know that the hospitals are being penalized financially. If you have a higher than expected readmission rate for certain conditions, you can be penalized up to 3% of your Medicare reimbursement, and not just the Medicare reimbursement for those conditions, your overall Medicare reimbursement. So ask your finance department what their reimbursement is, or what their Medicare reimbursement is annually, and then multiply that by 3%. It's not an insignificant amount of dollars. So we know that that's important because without that money, we can't function. We also know that we're looking at patient outcomes. We're looking at patient engagement. We're looking at why is just the hospital the ones being penalized? And that question has been asked over the past 10 to 15 years. And you've seen things happening in readmission reduction that have held other entities accountable. Post-acute services, physicians are finally being brought to the table about this as well. So what I'm going to intend to do here is provide you with a comprehensive overview of what HRRP's impact has been over the past 10 years. We're going to look at some key successes, the ongoing challenges, and some areas of growth. Also like to take a look at some projects about how people have adapted to the HRRP policies and what are some of the outcomes that we've achieved, both clinical and financial. But then we're going to end with, we keep leaving out one group about how we're going to be fighting off readmissions, and that's the patients. So let's also bring them into the fold and figure out how we can best serve them through health equity, through social determinants of health, through education and exploring patient activation and patient engagement. And I'll also be doing a little bit of a dive into some tech because I know everybody's all like, tech, we need to know about the tech that's coming. And we'll be talking a little bit about tech's role in readmission prevention as well.
Uh,
So go ahead.
Colleen, it's Maureen again. It looks like you might have other stuff open on your screen, and it
All
says
right, hold on a second. How's that?
you still have a black box at the bottom of on the side of your screen.
On the side of my screen?
Yeah,
All right, hold on, let me see
and
what's
at the
open.
It's on the right side, Maureen, at the bottom, the
right.
little black box.
Close that. Does that work?
I'm trying to grab it from here. Um,
So before when you had, you had a box open, it said notes.
Mm-hmm.
It was in the same shape as this box. I don't know if that's connected.
All right, hold on a second. Is that better? Oh,
it,
you guys can't see anything now because I paused it.
no, we can see it. There's still something in the lower right-hand corner. Well, now there's another one in the middle.
All right, so I'm going to stop sharing for a brief moment here. This was not happening
Okay,
during our practice. So give me 5 seconds. We're going to try to
okay,
fix this. How's that sound?
sorry.
No problem. Better?
We don't see anything.
Oh, great. Of course we don't. Because why not? Hold on a second. Let's go here. Let's go here. Let's go here and here. All right. And going to go into,
It's still there.
hold on, hold on. Let me see what I could do here. I've got everything else closed, so I can't tell you what else is going on here, but we're going to duplicate. Better?
Nope, it's still there.
I got nothing else open here, babe.
Yeah, I don't know. It said something about notes.
No,
And
I don't have any notes on
you don't
anything.
see it at all?
Nope.
Oh, okay. Should we just move forward? There,
Do-
there are, the slides are up for people to
Okay,
download.
great.
Thank you for trying.
Not a problem. All right, so our objectives, we're going to be identifying the primary drivers of hospital readmissions and how case managers can effectively address them. And this is your 1.5 ethics. We're going to be addressing CCMC Code of Professional Conduct Principle 7. 2, utilize data-driven approaches to assess and mitigate risk to foster collaboration across care teams to enhance patient-centered care and continuity. If you know anything about me, you know I am all about patient-centered care. Number 3, develop actionable plans to apply readmission reduction strategies within your own organizations by becoming familiar with the evidence-based programs that are already out there. Why reinvent the wheel when people have done it for you, including your esteemed president who got me started on readmission reduction. Read an article from her back in 2011 and it just like lit a fire under me. And I got to tell you, there was one time that I was doing a presentation for CMSA and she was on there and I saw her name in the attendees and I'm like, is this the June Stark? And we fangirled all over each other. It was embarrassing, but it was awesome. And the beginning of a beautiful friendship. Describe how using the readmission avoidance strategies covered in this lecture improve a client's health and promote wellness and autonomy. So that's principles of our principle number 2. And we're also comparing and contrasting readmission avoidance care measures that are conveyed to those that you are currently using in your own case management practice. So that's principle number 5. And you're all case managers and we all have to be held to a code of professional conduct. So you should know what these principles are. All right. Hospital readmission reduction. Let's start really quick just by setting the bar with what the definition is. It's a Medicare value-based purchasing program that encourages hospitals to improve communication and care coordination to better engage patients and caregivers in discharge plans and in turn reduce avoidable readmissions. The program supports the national goal of improving healthcare in America by linking payment to the quality of hospital care. And that's all, it's all about shifting away from, pay for service to pay for value. All right, so what's a readmission? Oh, this was the first couple of years of HRRP, we went back and forth. Is it just for readmission for that specific diagnosis? Is it this? Is it that? And it was flying back and forth. It literally took 2 years for everybody to figure out what we were all talking about because it's a huge issue, right? And there's a lot of money at risk. Basically, let's think about it. We're talking about CMS. We're talking about Medicare patients. There's billions of them, many millions, we'll say. CMS does not have a phalanx of case managers who are going in and looking at every case every day, trying to figure out if this is related to the one that happened, 3 weeks ago. So what they said at the end of the day is that it's all cause. So a patient could be discharged from a hospital on, let's say, Monday of this week with a diagnosis of CHF, and on the way home from the hospital, get into a car accident, end up back in the hospital, and that counts as a readmission. Not fair, but it is what it is. The original hospital stay is considered until named the index admission. That's the start of that. And anything after that for a prescribed timeline is defined as a readmission. Now, most common timeframes for researches out there, we're looking at 30-day, 90-day. If you're involved in any kind of a bundle payment, you know all about 90-day readmissions. And then 1-year readmissions, because we look at that to try to figure out mortality and morbidity as well. CMS for the past 15 years has been saying, we're going to be moving to 90-day readmission rates, but the only ones that have been really moved to 90 days is if you are involved in a bundled payment program. It's not overall yet. So why are we looking at this? So day one of nursing school, one of my most favorite teachers, scared the living heck out of all of us. Didn't say, welcome to nursing school. We're so happy you're nursing is such a fulfilling, role. No, she stood up in front of us, did not introduce herself, said discharge planning begins on day one. Know it, live it, love it. And we all went, no, we don't even know what that means yet. And we're scared. So I take the perception of failure of discharge plan quite personally, because that's what I learned. That's the very first thing I learned in school. Readmissions within 30 days are deemed potentially avoidable and are looked at as a failure of the discharge plan. So something went wrong that the patient couldn't be successful after leaving the hospital. In addition to the financial risk, we know that our readmission rates are publicly reported as a quality metric. They impact our facility's star rating. So if you've got a higher readmission rate, your facility's Medicare star rating, you could be doing everything else right. You could be having a 5-star year and you're only going to be a 3 or a 4-star. The penalties that are levied on facilities with higher than average readmission rates can be incredibly significant, and admissions that are identified as readmissions. So you've got that index admission, right? And anything after that is not reimbursed. So you're doing all this work for free. And the managed care organizations have also taken that up as well. All right, some statistics. Because where are we without our statistics? All right, average hospital readmission rate is of 2024. The average hospital readmission rate is about 14.56, varying from state to state, 11.2 to 22.3. Hospitals in Massachusetts have the highest readmission rate at 15.3 for state specific, and Hawaii reports the lowest average readmission rate at 13.87. Now, the readmission rate for 11.2 to 22.3, that has been overall, not just for 2024. All right, statistics over time. So I did a little bit of a timeline because I love graphics. 2013, we were at 19.8 overall readmission rate, with 34% of our patients readmitted within 90 days, and sadly 50.2% of our patients not having a PCP visit within 30 days of discharge. Yikes, right? We all know that the gold standard there is 7 days, and this statistic is talking about 30 days after discharge. In 2021, on the bottom, 15.5. So we've done some good work. We've dropped it 4.3%. 30% of our patients are readmitted within 90 days, and 48.8% of our patients did not have a PCP visit within 30 days. Okay, now 2023, 14.56. So we're still dipping down. Readmitted within 90 days, that data is not available yet. And we know that 50% of our patients still have not had a PCP visit within the first 30 days after being discharged. So we're doing really great work on everything except getting our patients in to see their PCPs within 30 days. So costs that are associated. So let's take a look at this. So in 2015, $26 billion Medicare spending on readmissions. 2019, $29 billion spent on readmissions. And in 2022, we were back down to $26 billion, but that was only because pneumonia was removed from calculations under a COVID-19 exclusion. For CHF in 2012, 34% readmission rate with $65 billion in care costs. In 2019, 21.9% readmission rate with $43.6 billion in care costs. but now we're bumping back up in 2022 to 23% and $54 billion in care costs. This is not an area where we can take our foot off the gas pedal. COPD 2012, 27% readmission rate, 32.1 billion. In 2019, we have 19.7% readmission rate with $49 billion in care costs. Why? Because we're doing a better job at readmissions, but the care costs for our COPD patients, that's what's really getting. And in 2022, we've got a 19% readmission rate, but overall, we're spending $60 billion in care costs for our COPD patients on an average nationally. In 2023, from the 5,236 hospitals that Medicare assessed for hospital readmissions, 2273 or 42% were penalized for readmission rates exceeding our 30-day risk standardized readmission rates. For 2023, the pneumonia diagnosis was excluded. It will return to the evaluation for 2025. So we had about 200 hospitals that did not get dinged for readmission rates that were penalized in 2022. I anticipate that we will see this number go back up in 2024, 2025 as the pneumonia diagnosis returns to the calculations. So some of the root causes of readmissions. Why are patients coming back to the hospital? We got clinical drivers. We got the diagnoses that were chosen. They're life-limiting diagnoses, chronic conditions, right? We have medication issues. We already talked a little bit about the follow-up issue. But we also have non-clinical drivers, social determinants of health, health equity, and that overall patient perspective that we all keep forgetting about. So the conditions that are involved here: acute myocardial infarction, AMI, chronic obstructive pulmonary disease, COPD, heart failure, pneumonia, again, excluded for 2020 to 2024, coronary artery bypass graft or CABG surgery, and then elective total hip or total knee arthroplasty. Medication adherence, the extent to which our patients take their medication as prescribed. We know that this is a crucial factor for effective disease management and therefore for reducing hospital readmissions. We know that non-adherence leads to suboptimal health outcomes, increased morbidity, and much higher healthcare costs, because if the patients are not taking their medications, then they're going to end up being readmitted over and over and over again. CDC reports about 50% of patients with chronic diseases do not take their medications as prescribed. 50%. Why? Because the side effects, because they forget, because they don't have anybody to help them. Myriad of things. Medication non-adherence contributes to direct healthcare costs ranging from $100 to $300 billion a year in the United States. Wow, that's huge. Non-adherence is associated with higher rates of hospital readmissions. 2.4 or 2.54 times higher odds of a 30-day readmission for patients that do not adhere to their medication regimen compared to those who do. And medication-related problems are significant contributors to our hospital readmissions. We're talking about prescription problems. We're talking about side effects. We're talking about adherence issues. We're talking about access to medications as well. You're talking about a patient whose insurance may not cover that particular medication, but nobody's taken a look to see if they can or can't. Patients who are, in a donut hole, which thankfully has gone away, but that was a huge problem previously. I can't afford my medication for 3 months out of the year. What are you going to do about that? Follow-up, timely follow-up, outpatient. That's where the patient care needs to be happening, is in the outpatient arena. Timely follow-up appointments are associated with reduced 30-day all-cause readmission rates. We know that there's been systematic reviews, meta-analyses. There's been projects around this. Let me see if I could get this right. Outpatient follow-up visits were linked to a 21% lower risk of 30-day all-cause readmission rates for heart failure patients, reported by a paper out of the CDC. Wow. I can tell you about a project that I actually helped out with one of my doctoral prepared nurses he's a nurse practitioner, and he noticed that he was having some issues with his patients following up after they'd been in the hospital. And he had a significant readmission rate. And he's like, I got to do something about this. So when he was working on his doctoral thesis, he said, let's do readmissions. I said, great, I got all this stuff on it. And what he wanted to do was use telehealth to do that initial follow-up visit. And then if during that telehealth visit, he assessed that the patient needed to come in because they were looking a little off, then he would ask them to come in. But he went from like a single digit follow-up visit within the first 7 days to 100% follow-up visit in the first 7 days and a 0% readmission rate for the length of his project, because he was able to identify people that needed to come in, and then he actually put in place, instead of just that one follow-up visit, he would call them back up. Hey, how you doing? He carved out some time, but he showed that having those more frequent visits, those more frequent touch points, but he had the initial follow-up within 7 days. It was great. I was shocked by it. It was incredible. Early post-discharge follow-up facilitates better care coordination. You can nip things in the bud. Studies have shown that readmissions normally are occurring anywhere between day 5 and day 21. So that 50% of patients that aren't seeing their doctor or provider within the first 30 days, they've already been back in the hospital because they didn't get seen within that critical first week of being out of the hospital. We can address our potential complications promptly. We can adjust treatment plans. Hey, this medication is doing this, this, and this to me. We usually see those side effects, within the first few days, right? Reinforce patient education. You know that this is important. You know that you have to take this medication as is. Enhancing patient engagement. Timely follow-up visits encourage our patient engagement in their care. And we'll talk a little bit more about that later on. And it also is going to decrease healthcare costs because we're decreasing the likelihood of readmissions. Keep in mind also that Medicare has implemented payments for transitional care management services to incentivize early post-discharge follow-up. So providers in the outpatient can actually get paid a little bit of extra when they're doing those visits to help pay for whatever they're doing to facilitate that. Look, and excuse me. And all of this really does speak to the CCMC Code of Professional Conduct Principle number 2. There'll be a pop quiz at the end. No, not really. Non-clinical drivers, social determinants of health. I'm not going to spend a lot of time talking about social determinants of health. Why? Because we are the originators of the concern over social determinants of health. We, as case managers, no matter what our discipline is, have known for the longest time that social determinants of health, transportation, housing, food insecurity, health literacy, all the other things that come under there have a huge impact on a patient's health. And we have been banging that drum for over 20 years. It has just been recently that the rest of the world has caught up with us. So yay to us, people are finally listening, but also looking at health equity and, how can we make sure that patients get equal care across the board? And also the thing that nobody thinks about is the patient's perspective. And I'll talk a little bit about that later on when I'm talking with June. So social determinants of health. I don't know if I put mine and Nancy Skinner's favorite slide in here. I forgot if I did or not. We'll see. Non-clinical drivers. So we know that socioeconomic status has lower socioeconomic status is associated with higher readmission rates. Patients from disadvantaged backgrounds, inadequate health literacy, having financial constraints, all contributes to the increased likelihood of a readmission. One of my favorite patient stories about this is I had a patient who was readmitted several times within, like a very brief, like 3 or 4 months. And it was like clockwork. Every 2 weeks, she'd be back in. And we finally went in and I said, I need to explore this with you. I need to figure out what's going on here. And she goes, well, you guys keep sending me home and I'm still sick. And I'm like, well, what do you mean? She goes, well, I still have heart failure. And I'm like, has anybody not explained to you that this is a chronic condition and that you'll always have this going forward? And she was shocked. She kept coming back to the hospital because she hadn't been cured. So we didn't do a really great job of educating our patient, and we assumed that she understood what chronic meant. But that just goes to show that, health literacy is important. If you know me, health literacy is one of my big, gigantic soapboxes that I will stand on and scream on all day long. But just simple things like that. One word, chronic. Patient didn't understand what that meant. We need to take the time and stop talking in our own jargon and speak in our patients' languages, not just different languages, but in the way that they can understand it. Our patient's education level can impede their ability to comprehend discharge instructions and manage their own post-hospitalization care. So my husband was just discharged from a facility after breaking his pelvis, and the packet was about this thick, going through it. And he's going through it all and he's trying to figure out what it all means. But there's so much in there. And he was so overwhelmed by it. And he's still on pain medication because, you broke your pelvis in 3 places. It's going to hurt for a while. He couldn't comprehend the discharge instructions. The way it was organized, I was having trouble figuring out what it was meaning. It was very patchy. Everything was all over the place, not very well organized. So making sure that we give people actionable information in a way that they can understand it. Housing instability. Unstable housing situations really can hinder recovery by limiting access to a safe environment that's conducive to healing. I had a patient once who was readmitted several times, and we found out that, and we had an incredible social worker who said, that address it doesn't look right to me. So she took it upon herself after work to drive by the address, and she was involved in the city government in the area that the hospital was in. And she said she knew something about the address just struck her wrong. And she went driving by the house, and it's got all this condemned signs all over it and yellow tape and stuff like that. The patient had been going back to their home that had been condemned, no running water, no nothing, no electricity, no heat, no nothing, and breaking back into their house. And then when they'd get sick enough, they'd, find their way out and get to a hospital and then go back to that house. But the social worker taking the time to drive by that address and saying, oh, no, 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 we were then able to make a report to Adult Protective Services because she was actually breaking the law and breaking back into the house. Social support, but not everything has to be that bad, right? It doesn't have to be a condemned house that somebody's going back to. If you've got a patient who does not have a stable address, where there may be couch surfing with friends, here and then here and then here, that kind of unstable housing situation is not necessarily conducive to getting better. You've got a lack of a robust support system, might result in having inadequate assistance, might result in not making those follow-up appointments in a timely manner. They might not be able to manage their own medication. And if you've got a patient who's got multiple follow-up appointments with multiple specialists, they may have trouble having somebody take them to all of those. So, I work full-time. So I have put together a team of people to manage my husband's care after he got discharged home. So I take care of all of his medication management, like get his box all set up, and his friends he's got a very small little community that he lives in, and all of his friends go out there and they, check in on him once a day. And then this person takes him in for this appointment. This person takes him in for this appointment, which are local to his area. And then I take him into the city for his leukemia follow-ups. So it does indeed take a village to not just allow people to live and to make money and support themselves, but also to manage somebody who's in a health crisis. So keep that in mind when when a family member says, oh, don't worry, I got this all, because I'm going to tell you from experience, you don't got it all. Sorry, baby puppy is having an attack right now, and she's just wanting to come and say hi. So say hi to the baby puppy if you can see her. Predictive value of social determinants. Incorporating our social determinants of health into predictive models really does help us to identify patients that are at a higher risk for 30-day readmissions, because 80% of your health issues are related to the social determinants of health. So if you are not taking social determinants of health into your predictive models to try to figure out which patients are going to be higher risk, then you are only going to capture 20% of the patients that are at higher risk. All right, guys. Sorry, the dogs are losing their minds this morning. The impact, we know that patients that are residing in socioeconomic disadvantaged neighborhoods have a higher likelihood of readmission. That's been all over the literature, and the most recent one is in 2024. Implications, well, what do we got to do about this? We need to do a comprehensive patient assessment, including social determinants of health. Now, I got to tell you, everybody else was probably like, oh, we got one more assessment we've got to do. But the case managers were all like, yes, social determinants of health is finally being mandated as an assessment in 2024 by CMS. This is important. People are finally taking seriously what we've been talking about for decades, and that's incredible. And then what do we do with that? Well, if you're just collecting data for data's sake, that's not going to help anything. So they're asking us to come up and figure out some targeted interventions, like giving some stable housing resources or figuring out services in the community that can help them shore up their social support services, because that's going to help mitigate the risk of readmission. And then we also have to develop those policies. So that CMS came forward and said social determinants of health are important. Therefore, we have a policy now that you have to do a social determinants of health assessment on everybody who is admitted inpatient to a hospital. Yay, we love that. If you have any questions, please put them in the chat or in the Q&A, whatever June told you to do earlier. All right, health equity, looking at encompassing the fair and just opportunity for all individuals to achieve optimal health. We know that the care given in Chicago is different from the care that is accessible in Southern Illinois, where there are maternity deserts, where we have, and vice versa. When we look at the city of Chicago, it's very hard to get to a grocery store. There are very few grocery stores on the west side and the south side of Chicago. And I remember when I was working at St. Bernard Hospital, which is at 63rd and the Dan Ryan Expressway, which is on the south side, it takes 3 buses to get from St. Bernard to the nearest grocery store. Can you imagine doing groceries, 3 buses back and forth? Yikes. So making sure people have access to everything that they need is, and health equity. We know that social determinants of health. Can you get to your food? Can you get to your doctor? Okay. So why is this important? Well, we know that studies have identified that consistent racial, ethnic, and geographic disparities have an impact. Areas with those disparities have an impact on hospital readmissions. The data over almost a 10-year period shows that certain minority groups and residents of specific regions experience higher readmission rates, usually due to the influence of social determinants of health on health outcomes. Yikes. I know Nancy Skinner's on here, and Nancy lives in rural Tennessee. So we have a rural SIG, a special interest group at the CMSA national level, and listening to the conversations that go on that SIG or reading the notes from them it's very eye-opening. They just did a presentation not too long ago talking about rural healthcare and some of the challenges. I mean, it was eye-opening. I've never really lived in a rural community, so this was new ground for me. And I was like, wow, I would have never thought the issues that they face on a daily basis. Patients from a lower socioeconomic background often face challenges like limited access to healthcare resources, inadequate health literacy, which can happen to anybody, and financial constraints. All, of course, lead right back to that potential for readmission. All right. Insurance status. So I live in Illinois, and we have expanded Medicaid, and we have managed Medicaid plans. But the managed Medicaid plans all have very, very, very narrow networks for subacute rehab, for acute rehab, for home health care. So you might be calling all 15 home health care agencies on that list, trying to find one that has staffing to be able to take care of the patient that is under that insurance. Excuse me for a second. It's the morning. I think my body's just starting to catch up to me. So insurance status, do they have insurance? What does their network for their insurance look like? Uninsured or underinsured patients do have barriers to accessing follow-up care as well. Have you seen a PCP that will take an uninsured patient? No, because they're a small business and they need to get paid. So trying to get somebody who's uninsured into a primary care physician is a challenge, right? All right. Implications, we need comprehensive strategies, period, exclamation point. We need to address all of these disparities, not just one at a time. Everything needs to be addressed. And I know that's hard, everything all at once, right? Healthcare systems, we are a big healthcare system to implement comprehensive strategies that include and consider social determinants of health. We need to be able to work with our community partners because the hospital systems and the hospitals can't do it all themselves. We know this, and we shouldn't have to. There are plenty of community partners, no matter where you're living, or if they're not anything in your area, talk to your lawmakers about, hey, we need some of this stuff to support our patients out in the communities. And making sure that everybody understands that, the CMS new rule for SDOH is important. We need to capture that data. This isn't something that we're just doing to click a box. This is actionable items that are going to improve the access to care and the quality of care for our patients. Drink time. Oh, patient perspective. I told you this is one of my favorite things these days. So patients' perspectives of hospital readmissions vary. There's not a lot of literature out there. And what I've gotten is a lot of, talking to our patients. There has been a study that was done comparing patient and provider views that found that patients were more likely to consider that their readmissions were preventable compared to the physicians. Patients are perceiving readmissions as avoidable events. However, they are also partially accountable for them as well, because if they're not following what we're asking them to do, especially with medication adherence, as we talked about earlier, there's an accountability there. There's also an accountability on the side of the patient or the physician, the provider, the healthcare team to make sure that the patient is engaged and activated as well. We'll talk a little bit more about that in a bit. Making sure that our patients understand what their healthcare condition is, that they can manage. This was one of my favorite projects. I thought I was going to save this for a little bit later, but I'll talk more in depth with June about it. I did a health literacy lab at a facility that I worked at about 5 years ago. And when we brought our patients into this lab experience, we asked them to rate on a scale of 1 to 10, how confident did they feel in taking care of themselves once they were discharged? And you'd be surprised at how many people went in there and went, I can do this. I know everything. And then they went through the 5-station lab experience and they came out and they went, I thought I knew what I was doing. So, they're walking out and they'll say, yeah, I got this. But in truth, until you actually re-educate them about what it is that they're doing, they really don't. And they're just, nobody wants to be perceived as I can't manage myself. But this is also an opportunity for education and conversation about, hey, you know what? And this is one of my most favorite things in Teach Back. I just need to make sure I did my job right. Can you tell me what you heard when I said that to you? let's talk about how you're going to manage your health at home. Can you tell me what you're going to do? How are you going to take your medication? What does your diet look like? These are the kinds of things that we need to engage our patients in conversation with, rather than at the end of a 4-day stay in the hospital, we're going through these discharge instructions with them. And if you've ever been in the hospital, usually when I'm in front of people, I'll be like, who's been in the hospital recently? Within the past year, people raised their hand. When they were discharging you, did you listen to anything that the nurse was telling you at the time of discharge, or were you just trying to sign that paperwork and get the heck out of there because your ride was waiting downstairs? Let's think about it that way. And I'll catch up on it when I get home. This is the perfect opportunity to ask questions. Patients can actually reasonably predict their own risk of readmission. In a survey of some general medicine patients, they believed that they were at higher risk for readmission and were more likely to be readmitted within 30 days. They were self-aware. They knew that, they had this condition. They had been educated. They knew that, maybe they weren't managing themselves correctly at home. Maybe they had some risk factors at home that we weren't aware of, but they were aware of, so they knew that they were going to be coming back. These are the things that we need to explore with our patients. Keep in mind also that these readmissions can negatively impact our patients' perceptions on their own healthcare experience. While it may be partially, a shared responsibility, they're feeling frustrated. They're anxious. Remember that lady I told you about? We told her that she had a chronic condition. She didn't know what that meant. She was very dissatisfied that she had to keep coming back to the hospital to get cured. And she was very upset. And why didn't we cure her when we went every time she's in the hospital? We needed to do a better job. Okay. Implications for us. What do we got to do about this? Well, we have to make sure that we understand that our patients see readmissions as negative experiences. Not everybody wants to be in the hospital multiple times every month, right? We need to do a better job of communication with discharge instructions, follow-up care, potential warning signs for complications. We need to include them in the care planning and the discharge planning and the decision making, because that's how we're going to engage them and activate them in taking care of their own health. And we should also make sure that we actively seek out and address any kind of concerns that they may have about their readiness for discharge. We all live and die by the length of stay, but one more day might make a difference. So to that end, throughput versus readmissions. We know that throughput is the effective movement of patients along our internal care continuum. And then length of stay, we have our own issues. We have the GMLOS that we live and die by, and also that DRG payment connected to that, once we start going over that GMLOS, we're losing money. And let's face it, we're losing money anyway. Columbia Business School in 2020 did a study, said, should hospitals keep their patients longer? 6.6 million Medicare patients were followed. Compared the benefits of an additional one-day hospital extension to those who were in outpatient care in terms of reducing readmissions, mortality rates, and costs. They found that waiting one extra day reduced the mortality rate for a risk for pneumonia patients by 22%, reduced the mortality risk for heart attack patients by 7%, resulted in 5 to 6 times more lives being saved compared to outpatient care, and decreased the risk for readmission for severe heart attack patients by 7%. So the hypothesis was, if we keep the patients in the hospital for one more day, that will help them reach a higher level of stability, giving the physicians and nurses more time to educate them about their post-discharge instructions and behavior. So letting high severity heart failure patients stay in the hospital for one more day decreased their readmission rate by 7%, and keeping all pneumonia patients who have Medicare fee-for-service plans in the hospital for an extra day would save 19,000 lives per year, they extrapolated out. Yow. But then we also know the converse of that an additional day in the hospital increases your infection rate or infection risk, increases your medication error risk, increases your pressure ulcer risk. So which one do we do? We also need to talk about protecting patients' rights and dignity. They have the right to autonomy. We got to reduce avoidable readmissions, but if we do that, we need to make sure that we're empowering and equipping our patients to manage their health at home, because that's really where they want to be, right? They want to make decisions about their care. They want to be empowered. We need to ensure that we've got equitable care, addressing social determinants of health, making sure that we're reducing those disparities and getting our patients equal access to care and support. Promoting health literacy. You guys are get sick and tired of hearing me talk about it all day long. Clear, understandable discharge instructions, clear, understandable information about a patient's rights, a patient's ability to understand what the next steps are for them, how to manage themselves at home. That way we can help promote informed decision making. Maintaining that continuity of care. Nancy and I are both huge advocates about handovers, not handoffs. Continuity of care, effective care transitions. Don't just rely on the written word or faxing things to the PCP. If there's an opportunity, have a conversation with that office and hand that patient over. Most PCP's offices don't know the patient's been in the hospital with the hospitalist models. So, that may be the first notification that they've had that their patient is in the hospital, is getting this fax or this email saying, hey, patient XYZ has been in the hospital for 6 days with pneumonia. And they're like, oh, really? And now they've got to try to fit them into their schedule. Protecting a patient's well-being. We know that unnecessary hospital stays have risks. So we want to reduce physical and emotional stress. We want to improve our patient's overall well-being. Again, back to that. Should we keep them one more day? Should we not keep them one more day? Should they even be in the hospital at all? Can we manage them at home? We need to foster trust in the healthcare system, because these consistent readmissions are eroding that trust because we're not curing or getting them set up for success at home. And we want to support their independence for as long as possible. We know that most of the diseases that are on or conditions that are on the list are chronic conditions. CHF and COPD are always the ones that get the big spotlight. Those are chronic, lifelong, life-limiting conditions. We know that our patients are going to be on a downward trajectory. So we need to be able to support them at home, give them that control for as long as possible, and support their independence until it gets to a point where they can't anymore. But wouldn't it be great if we were able to give them as long as possible to be able to do that? All right, quality of care and cost reduction, ethical discharge practices, avoiding premature discharges, preventing the revolving door admission, readmission, doesn't serve anybody. Making sure that we have equitable health care delivery, addressing the social determinants of care, and then tailored care plans. We all have clinical pathways and they're evidence-based, but don't forget the person that's at the middle of that. You're going to have to make some adjustments for that particular person's situations and needs. We're looking at improving the quality of care by comprehensive care coordination, patient-centered care, reducing costs, lowering healthcare expenditure through efficient resource allocation. Again, we want to enhance patient satisfaction and trust through a better patient care experience that encompasses holistic, and I will channel Ellen Fink-Samnick here. I misspelled that. It should be WHOLISTIC, for the whole person, not just holistic, but holistic. All right. What's our role? Well, our role is coordination across the continuum of care, my friends. We're doing comprehensive discharge planning, early risk assessments, multidisciplinary communication, making sure the entire team knows that this patient has these issues with social determinants of health that are impacting them coming back, making sure that they understand that, through our conversations, this is what we found out. The information that we get doesn't work if we just have it right here. If it never makes it into a note, if it never makes it into a conversation, and don't rely just on your notes to communicate with the rest of the multidisciplinary team, please. That's number one pet peeve of mine. Oh, read my note. No, we're having a conversation now. Every day, you probably have a formal multidisciplinary communication with your care team. Everything needs to be discussed at that point in time, not just is the patient ready to go. So some tools and models for success. These are evidence-based practices. This is where we get into the fun here. There's 2 risk assessment tools. The LACE score is like the big one that everybody is very familiar with. But in doing research for this book, I discovered the hospital score. And actually, I prefer the hospital score. The LACE tool, in my estimate of it, it's very superficial. The hospital tool, and LACE, but the hospital tool has 1, 2, 3, 4, 5, 6, 7, 8 letters to it, so it's a little bit more in depth. Given my druthers, I would prefer to use the hospital score as well, but both of those don't take anything into consideration about the patient's perspective. Yay. Evidence-based models, Project Red, the re-engineered discharge is living now on the AHRQ website. It has been kind of, what's the word I'm looking for? Endorsed by AHRQ as the best practice in readmission reduction work. And thanks to this chapter for me getting to meet one of my heroes, Dr. Brian Jack, and I'm now actually working with him on Project Red stuff. So cool. But this chapter got me in to meet him, and I'm just and you guys are awesome. The Care Transitions Intervention, or CTI, and then Boost, Better Outcomes by Optimizing Safe Transitions, is a great program that can be used when going between care settings, such as hospital and skilled nursing facility, hospital and acute rehab, hospital and LTAC. So we'll take a little stroll through all this stuff. We need comprehensive discharge planning, individualized care plans, tailor the discharge instructions to meet the patient's needs across the patient's domains of medical, social, and emotional, educational, using plain language, 3rd to 5th grade reading level, culturally appropriate communication methods. There is a potential, if you're an Epic shop, there is a potential to get your discharge instructions translated into just about any language or dialect out there. I mean, I was just talking to our patient experience team yesterday because we're putting together some stuff that's patient facing, written at a 3rd to 5th grade reading level about the continuum of care and about what each of the levels of care, so LTAC, skilled nursing facility, subacute rehab, et cetera, do, what your expectations can be there. And we wanted to get it translated into about 6 languages to start off. And they sent it back to me and they said, we have 144 languages and dialects right off the bat that we can translate it into. And I was just like, wow, can these be done on demand? And they set it up for us to be done on demand. So yay us. We have this ability to just be able to pull, a subacute rehab fact sheet off in Cantonese. Go figure. I love technology. Patient and family involvement. Well, if we're including them in the discharge plan, in the comprehensive planning for their success after they leave the hospital, that's what I like to call it now, we need to engage them in that, because if we engage them in that and we include them in that and they're part of that planning process, hey, guess what? They're going to be more I hate using the word engage again. They're going to be more engaged in being a part of it. They're going to be more engaged in seeing it through. And if it's something that they helped come up with, better chance for success. Excuse me. Medication reconciliation. Oh my goodness, the bane of my existence these days. Accurate medication lists. I've now had 2 family members suffer from an inadequate medication reconciliation. If you've heard me speak before, you know the story about my mom and her medication, but now we've just recently had one with my husband. And, medication error at both the acute facility and the subacute facility, where, there's something funky goes on when people take Norco and Flexeril at the same time. It's called serotonin syndrome. And because of his injury, he was given the Norco, and he also had a previous neck injury, which he was taking the Flexeril. Well, when he was in the acute care hospital the first time, he actually went a little altered. He doesn't mind me sharing this, by the way. And they called a code stroke on him. And a very smart young doctor looked at the medication list and thought, oh, he shouldn't be taking Flexeril anymore. And he discontinued the Flexeril. Sadly, though, when he went to the subacute rehab, that Flexeril was still on there. And so he got to the subacute rehab and they gave him the Flexeril with the Norco and he went again. And I was like, no, no Flexeril, no Flexeril, no Flexeril. And they took it off. And then a little later on, somebody noticed that Flexeril was still on there and they gave it to him. And he went altered again. So I noticed that when they discharged him from the subacute rehab, the stupid Flexeril is still on there. No. Accurate medication lists. Verify, update all medications every step of the way. If your patient is being transferred from floor to floor, you still need to do a medication reconciliation to make sure everything is still, especially if they're going ICU to med surg. Got a whole bunch of ICU meds you don't need on there anymore. Explaining to your patient the medication purposes, the dosages, the side effects. I just got done teaching all of the oncology nurses about teach back. We did a whole big refresher at the hospital that I work at, and I was part of that. That was so cool. But having them teach each other about medication as if you're the nurse talking to the patient and vice versa. And their eyes were opened by how much jargon they used, how they just really kind of skated over the surface of it. And then the patients were asking very, very good questions about, what does this do? How should I take it? There's an incredible video from the American Medical Association on health literacy. If you have an opportunity, check it out. It goes on and on about, we get these little bottles and it says take twice a day. Well, what the heck does that mean? Do I take 2 pills once a day? Do I take 1 pill in the morning, 1 pill in the afternoon? Do I take 1 pill in the afternoon, 1 pill at night? What does that mean? They're asking you for that information, but they're not asking you because they don't want to seem like they're stupid or like they don't know. People have pride, so remember that. And that comes across in this whole video too. That's a common theme. I don't want anybody to know I don't know. So put it back on yourself. You know what? I need to make sure that you understand. So I need to make sure that I did my job right in explaining it to you. There you go. And get pharmacy involved. In that health literacy lab I talked about a little while ago, the number one favorite intervention of everybody that went through that lab was sitting down with a pharmacist and going through all their medications and understanding what their medications were for and how they were able to move them around. We know that Lasix does certain things and people don't like taking it at 9 o'clock at night. Well, you know what? Maybe you can take it at 5. Maybe you could take it at 6 so you're not up all night. Scheduling timely follow-up appointments. We've talked about that one to death. Making sure that our patients have reminders through calls, texts, or written instructions. Telehealth options. If there is an option for a telehealth visit and your patient is able to utilize telehealth services, make sure that you check that out first. By all means, do it. It will increase their ability to follow up. It will increase the provider's time to be able to put eyes on a patient and engage your patient as well. Addressing social determinants of health, we've already talked all about. Using standardized tools and checklists. I know a lot of people don't like checklists because it's like, oh, it's like cookbook medicine or cookbook case management or cookbook nursing. But would you get into an airplane if the pilot and the co-pilot had decided to throw the checklist out the window and go, we know what we're doing? I wouldn't, because I want to make sure that T's are crossed and I's are dotted. And let's face it, when we're discharging our patients, it's just like a plane leaving the runway. You're sending somebody out there. You got to make sure that all systems are working. Medication reconciliation, follow-up appointments are done. Patient teaching is complete. The opportunity for maybe family education to come in. So using standardized discharge checklists is critical. Leveraging your electronic health record to flag high-risk patients so that you can give them a little bit of extra, oomph there. And it also help you streamline your discharge tasks as well. And then the risk assessment tools that are embedded, like the LACE or the hospital score or anything else that you're putting in there. Make sure that you're utilizing those. Care coordination across settings, hand off should be hand over. Ensure clear, concise information between care settings. Whether it's hospital to PCP, hospital to home health, skilled nursing facility, anything, they've got to have the most up-to-date information there. And then using transitional care programs also helps to support our patients during that period as well. Patient education and self-management, we're going to talk a little bit more about in a second. So post-discharge follow-up calls, these we're talking about some of our evidence-based practices. Telephonic phone calls, you either have one or you have phone calls that have a single post-discharge call where you go over everything under the sun in one call, or you have an organized follow-up program where you do that initial call and then you set up maybe a call next week, the call week before, week after that, as many as the patient may need. There's also been programs that do home visits after discharge and make sure that T's are crossed, I's are dotted, patient is, in a safe environment. Maybe a social worker can go out to the home and do an evaluation and get the patient linked up with other services. And then telehealth integrations, like I mentioned about my DNP student, phenomenal project, phenomenal idea that really did have some great outcomes there. The expansion of telehealth under the CARES Act has led to a significant increase for our telehealth utilization for post-discharge follow-up. April 2020, telehealth accounted for 46% of follow-up visits, but the proportion declined to 13% by September of 2020. Now, 2020 was a bad year, right? 2020, 2021. Data isn't in yet about how using telehealth for follow-up visits has rebounded, but I would expect that it has rebounded significantly. However, people are in the post-COVID kind of a mindset of going back to normal. But I would still suggest people utilizing telehealth as much as possible to do, especially that first post-hospital visit, so that we can see our patients within 7 days and not outside of 30 days. All right, so we've talked about current and the past. Now we're going to talk about the future. So who's responsible for readmissions? Well, it started out the hospitals. But who else is responsible? So we've got primary care providers who aren't seeing the patients within a 30-day period of time. And whether that is that they don't have space on their schedule to get the patient in, or they make the appointment and the patient doesn't show up. We have specialists because that patient still needs to see their specialists also. We have post-acute teams where, do we have staffing to be able to support these patients? Do we have bed availability? It goes on and on. What's the quality of care being given? How's the communication going? And then we have our patients and their caregivers who also have to share accountability in readmissions. They play a vital role by following their discharge instructions, managing their medication, attending the follow-up appointments. If they are educated very, very well in how to monitor their symptoms, they can catch things early. They can communicate with their healthcare providers in a timely manner. If you've got a person who is able to use their patient portal and they can text their doctor and say, hey, you know what? I'm feeling a little short of breath today. What do you suggest? Maybe the doctor can manage that through a text message or say, hey, you know what? I need to get you in here. I've got an opening at 3 o'clock today. I'll see you then. Having our patients engaged and activated makes them more able to participate, not just in the discharge plan, but also as a part of the care team, to be involved in the shared decision making. What do they want? It's been a long time. We've been talking about patient-centered care for a long time, but truly patient-centered care means that you're involving patients and their caregivers in all of the conversations, not just the ones that you need informed consent for. hey, this medication is just, kicking my butt. What else can we do? And well, this is what I do. Well, I need you to do better. I had hand surgery. My goodness, how long ago now? 4 or 5 years ago. And as things have it, I'm allergic to all forms of opioids. Lucky me, right? So had hand surgery, and I told the physician and the nurse practitioner when I went in there that I cannot take Norco, I cannot take Tylenol 3 with codeine, I cannot take anything that's got an opioid in it. I break out in hives, I end up in the hospital. We don't want that. So this was about 4 weeks prior. Informed them, and they said, okay, we'll come up with an alternative plan for you for pain management because it's my hand, guys. Okay. And it hurts. So had the surgery done. And as we are being discharged, they hand me a prescription for Tylenol 3 with codeine. And I'm like, I can't take this. And the nurse practitioner looks at me. She goes, what do you mean you can't take this? I said, I can't take this. I'm allergic to opioids. Well, I'll give you Norco. Norco's an opioid too. Well, what would you suggest? Can you look back in the notes of our conversation back about 4 weeks ago where I said ketoprofen works really well, or Toradol? Oh, well, Toradol can rip up your stomach. I said, well, ripping up my stomach is better than me being intubated in the hospital. This is the conversations we need to have with our patients, making sure that they're involved in the decisions that we're making. This was just hand surgery, writing a prescription for an opioid, go out at the door. That was not patient-centered care. And I was trying to be involved in shared decision-making, but I was shut out. That's another soapbox for another day. All right, we know our penalties are up to 3% of our annual Medicare payments for excess readmissions, and then we also are held accountable for outcomes under value-based purchasing as well. Moving beyond the hospital, the accountability is being extended to providers, doctors, health systems, skilled nursing facilities, subacute rehabs, post-acute providers. We have ACOs that focus on coordinating care across the settings. If you're involved in an ACO, you probably know more than I do about it. But really aligning incentives to reduce the avoidable readmissions and bundled payments. I was involved in a bundled payment program. It's exactly what it sounds like. You get this one big pile of money, the hospital gets it, and they spend it out on the patient. So, does this patient need acute rehab or subacute rehab, and for how long? And making sure that it's linked to outcomes using high quality, low cost providers that do a great job of making sure our patients get taken care of. That's the whole bundling of it. And it usually lasts about 90 days. Shifting the focus from to quality outcome versus volume of services. It's no longer heads in beds. It's making sure that we're giving quality outcomes, reducing readmissions. And that's what the BPCI is really focusing on. Collaboration, coordination across that care continuum for that episode of care. And then you also have the comprehensive care for joint replacement, similar program, coordinating transition, alignment of initiatives, making sure patient gets from point A to point Z appropriately with an eye towards quality of care and quality of the reimbursement versus just spend. So I spoke a little bit a while ago, that didn't sound good. I spoke a little bit ago about transitional care management, and these are the codes that the physician office, primary care offices can use to say, we did this to help facilitate care coordination. So they incentivize that comprehensive post-discharge care, not just, oh, you're here, 15 minutes, see you later, bye. Early follow-up, they get credit if they follow up within 2 days and they put that code in, they get an extra like $30. If they're doing a medication reconciliation, a true medication reconciliation, please, during their visit. If they're aligning care plans across providers and services, so they're, maybe your PCP is now connecting with the specialist. Let's say you had a knee replacement. PCP has seen you. They're now going to call the orthopedist and say, okay, I saw Jane and she's doing great, blah, 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 blah. Here's a concern that I had. I know she's going to see you next week. Can you talk to her about this? Doing a social determinants of health assessment and maybe making some referrals out from their office. They can claim that. Doing patient and caregiver education, not just the usual, but if we're talking about a higher level here. And each of these codes, each of these components gets them the ability to claim a little bit of extra dollars for that visit because of the extra work that they're putting in with it. Not used as frequently as you would think it is because it is time consuming. And you may need to hire an extra person to do like the care coordination or the social determinants of health assessment. And it does take a little bit of extra time. But also the early follow-up within 2 days, that's going to be one that, you've got to actually put shadow appointments on your books and be okay with overbooking yourself for a day. Drink. All right. Where are we at? Risk stratification models, predictive analytics to identify high-risk populations. Oh, we'll start talking a little bit about AI shortly.
So Colleen, just
yeah.
a second. So just to let you know, so on the schedule, you have 10 minutes left.
We're good.
And that was to include the Q&A. And there's only really like 2 questions in the Q&A.
Okay. I will be done with this very, very shortly.
Thank you, dear.
So risk stratification, predictive analytics has come a long way. I used to work at an insurance company. Our predictive analytics model was horrible back 20 years ago. Now it's really, really great. And by early intervention, you flag those patients, you can get involved with them more often, and then using data-driven decisions and algorithms to kind of identify them and move on from there. Remote patient monitoring has been around for a long time. That was one of the things that our home health agencies used to use to, market themselves back in the day. And then patient portals, making sure that our patients not only can access them, but can use them as well. But that's a great tool for our patients to be able to talk back and forth with their providers as well. Integrating social determinants of health into care models. We've talked a lot about SDOH and what the expectations are. And I've talked telehealth to death, I'm sure. Integrated chronic disease management programs, lots and lots of chronic condition management programs. I think just about every home health agency in the Chicago area has dedicated chronic condition management programs for CHF, for diabetes, for COPD. Just got to get our patients to those agencies if it's appropriate. Working on partnerships with community organizations, utilizing community health workers to support patients with navigation of their health and social services, and again, SDOH screening as well. Medication management, I won't bore you with this anymore. You know how I feel about it, but pharmacist-led medication therapy management, phenomenal idea. Who knows more about the meds than the pharmacist? All right. Policy beyond the HRRP, the IMPACT Act standardized our post-acute care measures. The Meaningful Measures Initiative focused on actionable outcomes. And then we were expanding our ACO models to make sure that we were encouraging collaboration across the care settings as well. Patient safety organizations, if you were here last year, you've seen this slide before. They're great. Get involved with them. You can have the slides. AHRQ, my friends, and the resources that are available on AHRQ. Early days interventions, community case transitions programs. I put all this stuff in there for you so that you have it. We've talked about it all previously. Evidence-based care plan or comprehensive care plans. There you go. There's your CTI, your RED, your Boost, Interact. And then the one on the bottom right-hand side is the one that I did in 42 hospitals across the country, which worked out really well. Not a lot's been done post-2022 in the way of coming up with new ideas, because most people will take one from column A, one from column B, and create a program that works well for their particular group of people, just population focus, population health. So pharmacist-led, primary care practice-led. I want to save enough time for June to do the podcasty questions with me. Safety net hospitals had higher readmission rates versus affluent hospitals. So at one point, that was a big issue. And now they've added social risk factors to the risk adjustment that has demonstrated decreased readmissions and associated penalties. So about a half of the safety net hospitals saw their penalties decline because they had a risk adjustment put in for them. And then the patient's role in readmission reduction. Are they adherent to their plan? What's their health literacy status? Are they engaged and activated? There's really no significant research available. I did a research project a little while ago, really when we had our patients come in, and I'll talk with June about this a little bit more. But the perspective of the patient is really just, it's so important. And we're not getting it because there's no work being done around it. So if our patients are engaged, we have improved health outcomes. They have an enhanced patient experience because they feel like they're part of the team. There's cost savings, and we have a more efficient health system. Key takeaways there. Shared decision making, I've probably beat that to death all day. Open communication, good information given to them, and use of the patient portals and the digital tools. And how do we activate our patients? Well, you activate your patients when you educate them. But you also have to realize that most patients are not on the same space at the same time. So using something like the patient activation measure, it's a tool that we can use to measure the patient's knowledge, skills, and confidence and motivation at that moment in time. Not everybody's going to be at the same space at the same time, especially if you've got a brand new diagnosis. People have a tendency to go through that whole grieving process, and they're disengaged and overwhelmed, and then they're becoming aware, but they're still struggling. And then they get to a point where they're like, I'm going to take action and take control here. And then they get to a point where they're maintaining their behaviors and they're pushing even further, even to not just being their own health advocate, but maybe being good peer mentors for people at level 1. We've got a ton of apps out there. I love apps to play with, but there's a ton of great apps out there for healthcare. And these are all the patient-facing ones. Healthcare or Heart Failure Manager. I just did one for heart failure. Heart Failure Manager, it integrates with the Apple Health app, and they can put in all their data, and it kind of makes a little journal for them. If you've seen me talk before, you've seen Simon, the heart failure coach, go on to that. It's hysterical. I love it. I play it all the time. And it helps people learn how to make good self-management choices versus going back to the hospital. More tech, AI. AI is being used in proactive patient management for chronic conditions. And I have added a link on here to a company called Hippocratic AI, and they have created bots, your chat bots, but bots that help do patient education and interaction after discharge to help reduce readmissions. So those phone calls that I talked about where, maybe you're making a phone call every week, maybe you can turf it off to a bot to do it. And there's, if you're feeling good, push 1. If you're not feeling good, push 2. But it's gotten better than that to where it's actually recognizing voice things. Some of the patients that are using this are reporting that their loneliness score is going down because they're having, good conversation with this bot. And when things get a little out of control, or the patient's like, I need to talk to a live person, it does get warm transferred immediately to a live nurse. And then I put a couple of case studies in here for you to take a peek at as well. But I want to save some time for my friend June to ask all of her questions.
Thank you, Colleen, for
Hold
that
on one
really.
second. And so here we are, future directions.
Oh, sorry.
No, it's okay. We're looking at drivers of a growing recognition of involving our patients as active participants. Healthcare doesn't happen to people, it happens with people. So that's my final thought for the day, aside from what June wants to talk about. Yay! Go for it.
Great. Thank you, Colleen. That was an amazing lecture. I knew it was going to be because I got a chance to preview your slides. I mean, it's years and years. I'm sure all of you could hear years and years and years of experience and research and publication of readmission avoidance. We're so lucky to have you. And just to let everybody know, like Colleen and all our speakers, they've donated their time. So we really appreciate you for educating us and sharing. Yeah.
Here they are. They're ready to go.
Yeah, and the raffle, we're going to do the raffle. So that's the one thing. I know you might be like looking at getting a drink, but we'll do questions really quick. There's a couple in the chat box, and then
Good.
we'll do the raffle. You get to see it. It's an app.
Awesome.
Yeah, it's exciting. So thank you for that. So last year, Colleen and I did a Q&A, and it turned really into be kind of like a podcast approach. And we got some comments, positive comments on it, on the evaluation. So we thought we would try it again. But
Great.
but really though, I mean, because of the time, and I did ask Maureen how much we can kind of run over a bit. I don't know if you want to peek in, Maureen, but
We can run over a little bit and shorten the break.
okay, so what should I look at? 5 minutes?
Yeah.
Okay, 5 minutes. Excellent. And then at the end of 5 minutes, we'll do the raffle. Okay. So hang tight, audience, okay, and participants. All right. So a lot of the podcast questions really Colleen covered in the content. And so let's stick with what the chat was. Is that okay, Colleen? And then
Sure.
if there's something,
Go for it.
yeah. All right. So one of the questions in the chat was any data with VNAs assisting with decreasing readmissions.
Tons. There is tons of data out there that show that nursing, that home health care helps with readmission reduction because you've got eyes on the patient. You've got the ability to have interventions in the home. You know, visiting nurse can call the PCP who's managing the program and say, you know, this is what I'm seeing. Mr. Smith sounds a little wet today. Let's say a CHF patient. Can I give 5 extra of Lasix? And that can head off a readmission right there. Normally they would have been going, I'm going back to the hospital. Patient now gets to stay in their home. Maybe the visiting nurse comes back out the following day to double check on them. And again, they've got that point of contact as well.
Wonderful. All right. If there's anything else, whoever asked that question, if you want to put anything more in the Q&A, then I could ask that question. Okay. So the next question was, where did it go? Post-discharge follow-up calls. Who's doing that in your organization?
Well, I'm not going to talk about my organization right now because I can't.
That's okay. We get it. So
yeah.
your general philosophy, how's
my
that?
general, my history. Let's talk about my history. Okay. My history of doing follow-up phone calls at one facility, we hired 2 specific navigators to do the follow-up phone calls for our CHF and COPD patients. And that seems to be in the Chicago market, that seems to be the thing. We hire specific people to do the follow-up phone calls. The program that I put together at Metro South, which got rolled out to 42 hospitals across the country, we specifically hired 2 people to come in, and nurses followed the patient they were the patient's case manager for CHF or COPD the entire time the patient was in the hospital. And then they were the ones calling the patient after discharge, that first post-discharge 24 to 48 after discharge. And then they were the ones setting up the phone calls every week for 4 weeks after the patient was discharged. And that gave the patients an opportunity to develop a rapport and a relationship with them, a trusting, symbiosis there, and was very, very successful.
Great. That's great information. Thank you for that. So this question kind of complements that. And what has been the most successful, in your opinion, on trying to engage the bedside nurses in patient-centered care and readmission reduction?
I think if we have good bedside education, then we have a better readmission reduction, because an educated patient is an empowered patient. An empowered patient is a patient who, depending on where they are in their idea of coming to grips with whatever diagnosis they've got, is going to be able to move forward with that. Again, going back to that patient activation measure, you may have a patient who's stuck in that one, doesn't want to deal with the fact that they have CHF or COPD. But once you get over that bridge, I mean, you just keep educating them and answering their questions. That engages them. Whether they get activated by it or not, that comes from inside the patient. This is why we have to include our patients in the group. We can't just be doing bedside rounds and talking to each other and not including the patient. I mean, I've seen that model so many times. We're doing bedside rounds, yes, but you're just sitting there talking about the patient in front of them. That's kind of rude.
Right, exactly. And I think staff nurses, I mean, most of the population know about readmission in a way, and engaging them and providing them education and including on rounds, sharing
Right.
that, the course of the care definitely may be, may help.
Right. But I mean, we've been doing this for over 10 years now, and
Yeah.
people have, just like they get alarm fatigue, they get readmission fatigue. We don't care anymore. No matter what we do, they're going to come back. Well, you know what? Let's go back and revisit what we're doing. And then maybe it needs to be relaunched, or maybe you need a little bit more focus on it. Or maybe you're just doing it by rote right now, and you're not really, you as the clinician are not really engaged in giving the information in the way that the patient can understand it.
That's a
So,
great way to approach it.
take it back, and if you need to start from ground zero again, do it.
Great, excellent. Excellent advice. So there was one comment from one of our case management leaders in our community, and she made a comment. She said that the CMS data for readmission rates and penalties was great. She really appreciated that. And then she said that she encourages case management leaders to ask their finance team members about reports indicating the commercial payer readmission penalties, because those can be high.
Very much so. Very
Yeah.
much so. We've got
That's
7 managed Medicaids here in Illinois, and each and every one of them has adopted the "we're not paying for a readmission." And I mean, they are stretching the definition, let me tell you.
The insurance companies are testing every boundary.
Absolutely.
Yeah,
And I
so
used to work for insurance. I get it, but at the end of the day, too, I mean, we all need to be on the same page with, making sure our patients have access to good care.
I stand with you on that for sure.